Hey, everybody. Great to see you today. Before we get started, I'm going to share a quick disclaimer slide. Okay, so this is the care breakout session for Dystroglycanopathy. My voice is going to fail on me today. The information and opinions shared by our panelists will be generalized statements and are not intended to be interpreted as medical consultation or a substitution for medical care. Please consult your local healthcare providers regarding any specific health-related concerns. This session is being recorded and will be shared on our public YouTube channel after the conference portal closes on August 31st. Recordings will be available in the next few days within the portal up until August 31st. All righty. So now we're going to have our panelists introduce themselves. Megan, you want to start?
Sure. I'm Meganne Leach. I'm a pediatric neuromuscular nurse practitioner, and I work at Oregon Health and Science University Dornbecker Children's Hospital and Shriners Hospital for Children, Portland. Great.
Dr. Konersman?
I'm Chamindra Konersman. I am an adult and pediatric neuromuscular specialist. I work at University of California, San Diego, and Rady Children's Hospital.
Great. Dr. Meyer?
Yes, I'm Hank Meyer. I'm a pediatric pulmonologist in Philadelphia. I work at the Children's Hospital of Philadelphia, and I've had a long-standing privilege of working with Rachel and the rest of the Cure CMD team and helping to provide pulmonary care and assessment.
Great. And Dr. Saade?
Hi, I'm Dimah Saade. I'm a pediatric neuromuscular neurologist. I currently work at the NIH with Dr. Carson Bonneman and Reagan Foley. And I trained at the University of Iowa with Dr. Kathy Matthews and have been involved in the yearly family dystroglycanopathy meetings.
Great, thank you. So given that our session is pretty small today, our Zoom host is going to allow our audience to unmute their mics and cameras so we can have a little bit of a free-flowing discussion. So he's doing that now. You are not obligated to share your mic and camera, but know that you have that ability. We just ask that you keep yourself muted if you're not speaking so that we can make sure that this recording is clear. And we do have a couple of questions queued up here. However, if any of you in the audience would like to start with a question, please feel free to do so now while I pull up these questions. Nope. All right, we're going to be quiet today. All right, so earlier today we had a plenary session on the concept of clinical trial readiness. Can we spend just a couple of minutes discussing kind of what that means in terms of specifically for dystroglycanopathy? This is a huge spectrum, but I'm sure everybody is curious about kind of where we're at on that in that concept. Dr. Saade, did you want to start?
Yeah, I think, and I'll go back to my previous talk from yesterday. The dystroglycanopathy, the most common is caused by FKRP mutations. And so really the numbers for the different genotypes are still very small. And it would really help to evaluate and group patients with early severe CMD dystroglycanopathies together to get follow-up in terms of natural history, and also get input from families on what are outcomes that are meaningful for them to help with the readiness for clinical trials.
Great. Does anybody else have something to add?
I think similarly to what was said at the previous talk about the clinical trial readiness, that it's also important to ensure that everybody is diagnosed. We have a genetic confirmation for everybody. And then if people can join registries, then we know where people are and how many people we have who might be interested in potentially participating in clinical trials. Because when we get to that point, which we expect we eventually will, we need to know where the families are, where the patients are, and how many people we could realistically expect to be participating in clinical trials.
So dystroglycanopathy is pretty complicated. We've got, what, 21 genes now and counting? Is that right? Do you expect that we're going to be looking for more genes? I know a lot of families, we probably covered this yesterday, but I know a lot of families are still undiagnosed from a genetic standpoint.
Yeah, I think the diagnostic odyssey for these families is going to continue. I don't think it stops at this point, and it's going to be twofold. It's going to there's going to be work to find whether there are mutations that are hidden and are not obvious on the regular sequencing of the genetic material. So intronic mutations or mutations that are missed or skipped, as well as finding potential new genes that are involved. But I think a good number maybe have mutations that are missed on regular sequencing.
Okay, so additional testing is often required to get to that mutation or mutations.
And it's going to be research-based testing, and that takes longer because it's research-based. And if the answer was obvious, it would have been found. So that's where you get to the harder homework to find the mutation. And it can be in the form of whole genome sequencing, so the whole exome sequencing or exon sequencing in general looks for sequences the coding part of the DNA that codes for protein. Whole genome is going to sequence the entire DNA, including non-coding areas that are in there, to see if there's anything hidden deep in there. And then to compare to readout from muscle specimen, from muscle tissue. So RNA sequencing on the muscle tissue to look for protein readout there. And in addition to that, Dr. Campbell yesterday talked about complementation studies that he does on fibroblasts to identify which one of the enzymes that add sugar to dystroglycan is impaired. And I think the limitation was that in certain disorders, it is the fibroblasts, so skin cells, may not be the best tissue to look for decreased activity.
Okay, great. Does anybody else have anything to add before we get to the next one? Yeah.
I will say that many of my patients ask me if it is, I'm so sorry, if it's possible to, like, what the next step would be. That would be typically to get on a registry, and I highly recommend Cure CMD-IR's registry, which is Cure CMD-IR International Registry. And many of my patients also ask me how many other people are there with their specific gene. And I sometimes only have one other family. Sometimes I have none. And that's very discouraging to them. But being on the registry is the first step. And then I also emphasize the importance of doing natural history studies. If anything, if you have learned anything from the Duchenne muscular dystrophy, is that we need to do natural history for all of these subtypes in order to be able to have an interventional trial that actually ends up coming to fruition. So once I state that, they understand the gravity and the hurdles that are actually in their way, but it also sets expectations so that a patient or a family can understand what it takes to actually get something that is meaningful at the end.
But I think that's also helpful, knowing that there are steps planned and steps in process, and that there's something is happening as opposed to just wondering now what, right? At least we have a plan, so that's part of the battle, at least. Great. Okay. So let's get on to community questions. One of the questions that came in just yesterday actually are about medications. Do you know of any medications that are helpful for behavioral or mood difficulties, self-harm? Many of the MEB kids have these difficulties along with significant sleep issues. Could you, one of you, address that?
I can get started. I think behavioral issues and sleep is going to be treated in the way, in a standard way where you would treat behavioral issues in sleep, regardless of having a dystroglycanopathy. And this is usually difficult because it's a trial and error it's an individualized trial and error process to find the medication and the dosage that works the best for every child. And then countering, and with that, balancing that with side effects of these medications, because most of those medications, the way they work to have an effect on the behavior that you want to decrease or limit, they do so by slowing down your brain or calming it down or depressing it a little bit. So one common side effect is that you may be fatigued, or they work by altering your brain chemistry a little bit. And so they come with side effects. This is why one would start them at a low dose and then try it out and see if there's improvement, or if you encounter side effects which tell you, okay, now I need to taper off and try something else. It is a frustrating issue, but there is no quick fix for that, and often it takes a long time. But I do think that with these problems, it's helpful to join a patient's community or a natural history, like at the Iowa Wellstone Center, because you get to connect with other families who may have children who have the same problems, but maybe from a different gene. So not exactly the same one, but the way they address those problems and their life hacks could be beneficial to other families. Down to things that we as physicians and clinicians don't have access to, in terms of what do you do at home? How do you change your home environment? And these could be helpful to just compare notes.
Absolutely.
Another
Dr.
thing
Meyer, I'm sure, oh, sorry, Megan. Go ahead.
I was just going to say, another thing to think about is that sometimes what works best is a combination of a couple of different medications, but in lower doses. And so it might feel like, particularly if your child has seizures, that you have this handful of medications that you're giving to them multiple times per day. But as frustrating and as difficult as that can be, sometimes that's what works best for your child. So as Dr. Saade was saying, is that it's important to make sure that it's personalized to your child and not just a one-stop shop snowball for your kid.
That makes sense. Okay. Dr. Meyer, I'm sure you have some comments about kind of the looking at this from the other point of view, and that lack of sleep can cause behavior problems. Did you want to comment on that?
Sure. Yeah, sleep is a time where where we start to see breathing difficulties in patients that have even mild neuromuscular weakness. And what can happen is that it prevents you from sleeping comfortably and smoothly enough to be able to benefit from REM sleep, where you get essentially your muscles all relax and you can recover properly. And if you don't get that type of sleep, then it interrupts your ability to function at your best during the day, whether that's cognitively or behaviorally. And so we have plenty of patients who, when they don't get adequate sleep, are not able to interact properly during the day, or have problems with behavior. And so if we see that happening during the day, then we often look backwards and say, well, is that perhaps because sleep is not adequate? And if it's not, does that mean that the patient either has obstruction because of upper airway hypotonia or low tone, or perhaps is the patient struggling to bring in oxygen and remove the carbon dioxide that the body produces during deep sleep, in which case having respiratory support with a non-invasive ventilator would be helpful.
Great. Anybody else have anything to add to that? Okay. Since we're on the topic of pulmonary care, Dr. Meyer, I believe you have a couple of slides to share with us and some kind of an overview.
Okay, let me share my screen here. Let's see, here we go. Okay, you see the slides?
Yes.
Excellent. All right, so this is just a little run through of the pulmonary management of patients with neuromuscular disease. And this is not specific to any particular condition, but sort of reflects some of the things that occur during a progressive neuromuscular condition. So everything starts, at least in my world, from respiratory muscle weakness. And then for a progressive condition, oops, there we go. The endpoint is respiratory failure, where the muscles aren't able to help the patient breathe effectively, to bring in the oxygen needed and remove the carbon dioxide produced. However, there are a number of different channels that this flows through. The first, and the main respiratory muscle over on the left, is the diaphragm. And so there's some conditions such as Duchenne muscular dystrophy where you have very focused diaphragm weakness. And there are other conditions such as neuropathies like spinal muscular atrophy where you get very pronounced chest wall muscle weakness. And then in a variety of different conditions, you can have core muscle weakness that leads to spinal instability. All of these interact and conspire together to add further burden on breathing, leading towards respiratory failure. And if we go from diaphragm weakness and chest wall muscle weakness, the biggest thing that we worry about is poor airway clearance, which then puts patients at risk for lower respiratory tract infections such as pneumonia. And anytime you're acutely ill, irrespective of whatever the neuromuscular condition is, that can lead to acute weakness. In addition, if you have trouble with maintaining an erect posture, either while standing or sitting, due to chest wall muscle weakness or spinal instability, you can develop kyphoscoliosis. Kyphosis is when you tip forward, and scoliosis is when your spine curves from right to left. Both of those together can compress the lungs, leading to low lung volumes. Low lung volumes, whether from external or internal forces, leads to smaller airways and an increased respiratory load. Respiratory muscle weakness, either at baseline or acutely, can lead to diaphragm fatigue. And if the diaphragm can't overcome the respiratory load, whether it's in a chronic or acute phase, then you have respiratory failure. There are a number of things that we have available to support this. We certainly have mechanisms to help with airway clearance. Our orthopedic colleagues can help with either bracing or doing surgery to help maintain the spine and chest wall in a proper position. And then, of course, we have ventilatory assistance that we can use when patients tip towards respiratory failure. So I want to briefly talk about airway clearance. And first, it's important to know or recall what we actually do when we cough. And the first thing is that we take a big, deep breath in, and then we almost immediately do a forced exhalation. And during the first quarter second of that, we're breathing out against a closed glottis, closed vocal cords. The pressure then builds up in the lungs, the vocal cords open, and it's kind of like taking your fingers off a balloon where you have an explosive flow of air coming up the respiratory tract and carrying secretions. So three distinct phases, all of which are important. We have ways of compensating. We can certainly help a patient breathe in more deeply. We can have help a patient breathe out more forcefully, and then we can do both together. And then there's some other mechanisms related to medications that and other techniques that we can also use as an additional measure. So these are three devices that we can use for inspiratory assistance. Over on the left is what we call a breath stacking device, where we have a mask over the patient's mouth and nose, and then a one-way valve, which is over to the right of that with the red arrow, that allows the patient to breathe in, and then a valve that does not let the patient breathe out, which is over on the left of that image. And what happens is that the patient just takes a series of breaths in, and then when they've breathed in fully, the mask is removed and the patient breathes out. The item in the bottom right is the Alpha 200, which is a device that applies what we call intermittent positive pressure breaths, or another mechanical way of doing breath stacking that's quite commonly used in France and some other European countries. The device in the middle is used quite commonly in the US, and that's the cough assist, which can be programmed to use as either an inspiratory assistance device or both an inspiratory and expiratory assist device.
Let me ask you a question there. Can you use cough assist with a tracheostomy?
Yes, you can. There's a single tube that leaves the cough assist and goes either to a mask or to a tracheostomy tube, or in the acute setting, an endotracheal tube. And so the interface with the patient is really inconsequential. It can be used in either situation. When we use it for inspiratory and expiratory assistance, we set an inspiratory pressure and then an expiratory pressure, and we set each to be applied for a period of time, typically with a pause in between. This is something that needs to be done using a trained therapist that can work with the patient to find settings that the patient can tolerate and are effective. I want to shift over briefly to talking about mechanical ventilation. There are two main components to doing ventilation. The first, and probably the most important, is how does the air get into the patient? The most common device, especially for nighttime use, is a nasal mask or a cannula interface. We can also do oral or mouthpiece ventilation, which some people call sip ventilation or sip and puff ventilation. You can also ventilate using a mask over the mouth and nose, which sometimes is done at night if you have a patient that has a hard time keeping his or her mouth closed. And then obviously you can ventilate through an artificial airway, such as a tracheostomy tube. There is sort of partial or full body ventilation, what we call negative pressure ventilation, that also can be used in some circumstances. The other part of this, of course, is the ventilator. How does the air actually get into the patient? And by far the most common approach is using what we call pressure ventilation, where a pressure is applied to the patient at the airway opening, at the interface, and then the patient takes a breath in based on how much pressure is applied. The old-fashioned way of doing this is using volume ventilation, which outside of the hospital is really not used anymore, except for very specific circumstances. So these are a selection of different nasal masks. And up until recently, the biggest problem that we had in pediatrics anyways was having masks that are made for small noses. And that has become less of an issue. There are actually some masks such as this one here on this very happy looking child that is actually specifically made for a pediatric nose. And so that the interface I find is by far the most critical part of this, because that is how the interface is maintained. And if a patient doesn't tolerate the interface, they can't be ventilated adequately. Here are a couple of other ways. This is mask over the mouth and nose, which we often will use in an acute setting. The device over to the right, which when I first saw, really concerned me. It looks sort of like an avatar mask, but some patients actually quite like it. And we use it in some of our younger patients. This is the device that we use for mouthpiece or sip and puff ventilation. It's a cannula, it's a mouthpiece, as you can see up there at the top. It has a circuit tube that goes through an articulating arm that can be mounted to a wheelchair, mounted to a table, mounted to a bedside table, really pretty much anything. And then it allows the patient to put his or her lips around the tube and then get breaths at whatever frequency they would like. There are two different types of ventilators. There are ventilators that are made to be used just at night for what we call bilevel positive airway pressure. And those ventilators are only designed to be used for part of the day. There are ventilators that can be used continuously for both nighttime and daytime ventilation. They're a bit more robust and are also a bit more expensive, which comes into play in getting them approved through insurance. And it's important to get a ventilator, have a ventilator that serves the purpose that for which it's needed. I just want to finish with one, going through, we talked a little bit earlier about natural history. This is just general data from the best natural history that we have in neuromuscular disease, which is Duchenne muscular dystrophy. And what happens essentially is that as lung function or lung capacity declines, there are certain phases where we see things such as beginning to have outpatient respiratory illnesses and illnesses that require inpatient hospitalization, a period where we start to see breathing difficulty at night and then breathing difficulty requiring ventilation both during the day and at night. And then there are a number of things that we can offer to address each of these issues. The first and foremost for having respiratory illnesses is having an airway clearance device like the insufflator exsufflator, which is the standard device that we use here in the US. And then using it not just intermittently, but daily. And then once we get into a phase where there's an increased risk of nocturnal or nighttime hypoventilation or respiratory failure, then we get a sleep study. And the general view is somewhere between 50 and 60% predicted in your lung function or vital capacities where that should be, that question should be asked, and a sleep study should probably be performed. And we typically see nighttime ventilation required below 40% predicted. And then when you get down to about 30 to 20% predicted vital capacity, daytime ventilation is often needed.
So,
Yes.
I have a question on that. How do we handle pulmonary function testing with kiddos that have cognitive impairment?
We don't do it. I was using that more as a sort of a flow of things that we see in terms of progression. Instead, in situations like that where we don't have objective data, then we can borrow from some of the additional motor function measures that are done by our neurology colleagues, or just look at the patient in general. And as I said earlier, if there's a patient that is clearly showing signs of behavioral changes or irritability during the day, I would first and foremost worry about whether that patient is actually able to breathe effectively at night and may need support. If colds are beginning to last longer than, say, a typical 5 to 7 day duration and are lasting up to 2 to 3 weeks, then that would be a situation where I would worry about whether the patient has an effective cough and can protect his or her airway, meaning swallowing effectively. And if that happens to be a concern, then we would want to go ahead and provide assisted airway clearance. So this final slide is just to point out some of the things that really need to be focused on. And first and foremost, it's recognizing when something's changing, both chronically and acutely. And with chronic changes, as I mentioned, there are things that can be done to add on to therapy. And then acutely, you need to recognize when your child is beginning to get sick, and then ask for assistance from the physicians and the medical team that are involved in his or her care. And to me, the first and by far the most important intervention is airway clearance. And I say that because one of the first things that you see in somebody that tells you that they're sick is they're coughing. And that's for good reason, because there is debris in the airways that needs to be removed. And so if you don't do that early in the course of an illness, then things can begin to accumulate, which can then make treatment and resolution of the acute illness a bit more challenging. The final thing at the bottom I just want to point out, and that is there's a lot of angst around the use or lack of use of a tracheostomy tube. And I really feel strongly that using a tracheostomy tube is largely a quality of life and a personal decision, and is not something for which there's an acute indication unless there's a separate airway issue. And getting to the point of being able to remove an endotracheal tube during an acute illness is largely based on how aggressively and effectively airway clearance is being done. So I'll stop there and see if there are any questions.
Great, thank you. Meganne, Dr. Saade, Dr. Konersman, do you have anything that you'd like to add based on your experience treating this population on the topic of pulmonary care?
I often employ the help of my colleague, my pediatric pulmonologist, very early, even if the patient does not appear to have any pulmonary issues. I explained to the parents why I'm bringing on the pulmonologist. It sometimes scares the parents because they're getting this diagnosis that they've never heard of, and they want to know why so many doctors are involved. And having a pulmonologist ahead of time, to have a sick plan in place, and for that pulmonologist to actually see the baby when the baby's well is pivotal. And I feel like it's a good part of the patient's care. Parents almost always understand the reason once you explain it to them.
Absolutely. And I think it's important to have that multidisciplinary care through your MDA clinic. So be in that clinic where you will have access to a pulmonologist, a social worker, physical therapists, all sorts of therapies, orthopedics if you need them, cardiology, and get to meet all the members of the team, as Dr. Konersman said, early on in health. So that you establish a long-term relationship. And really also in the real world, you need to get things through insurance, and these things vary from state to state, but your pulmonologist through your MDA clinic is going to have the best experience in formulating things the right way in order to have the proper documentation. And often they may have assistance from their office, from their nurses or coordinators who can help push that paperwork for you.
I think that, as I'm hoping that you're hearing from all of us, we cannot underscore the importance of getting early proactive care and getting your whole team involved early on, because the last thing you want to do is have an acute event where it's really scary because your child's in the hospital, and then meeting all of these team members and then having to make all of these decisions in a very scary acute setting where you've never met anybody from a team member, like from the team. And so just establishing the relationships early is just so important. And they can also help provide anticipatory care so that you are getting the best care for your child early on.
Great advice. Okay, thank you. So let's switch to the topic of bone density. Treating bone density. Do we do that with vitamin D? How do we measure what the bone density is looking like? Do we just treat it with calcium, vitamin D, and when do we start other medications?
Yeah, that is a very important question. And that goes back to the importance of your multidisciplinary clinic, where you will have a nutritionist who's very used to working with this patient population, and they're not going to say, oh, your child is underweight, they need to put on more weight to get on the regular child's growth curve, where when you have less muscle, then you may have less weight, and that's potentially not a bad thing, it's a good thing. But their nutrition needs to be assessed in a special targeted way. And part of healthy nutrition is good supply of vitamins and mineral and bone health too. And so it's often the nutritionist or your MDA clinic that's going to screen for these things by measuring vitamin D level, calcium, phosphorus, and other markers of your overall nutrition status and your bone health. So I think that's the initial step to monitor for these things. And then based on your levels of vitamin D, calcium, that can determine whether you should be on a multivitamin with vitamin D, and that's usually a much lower dose of vitamin D, or whether you should take higher doses of vitamin D that then require a prescription and then a follow-up of your vitamin D level. Bone density in children is a little bit more tricky because of difficulty in finding standardized values that are good to compare your child against, and also doesn't do as well if you have contractures too. That makes them a little bit harder to interpret. So I think starting up with healthy nutrition and healthy values of vitamin D and calcium is a good place to start from. And then bone density, that may come in later on especially if you've had X-rays that show osteopenia, or if there's any concern that you might be at risk for a fragility fracture. But that's at that point where you would probably want a pediatric endocrinologist to be looped into your care team from within your multidisciplinary team.
Great.
Also understand that any bone density scan that is done is probably uniformly going to show low bone density. Don't be alarmed by that. That is very common, and it's actually a normal natural history component of having any muscular dystrophy, including the dystroglycanopathies. And don't be alarmed by that. If for example, the endocrinologist or somebody within the team actually orders a bone density scan, it is going to be low. The problem that we have is how to interpret the report that you're getting and what to do about it. That's where we don't have good care guidelines, because we don't have evidence or data on which to draw conclusions. So it's actually very difficult doing bone density scans, because I don't know what to do with the data, and I sometimes don't order it because there's nothing more to do than what my nutritionist or endocrinologist is already doing.
And a lot of centers won't do bone density scans on children, right? So that's part of the barrier to getting more data, is that that's not considered part of the standard of care, and they're considered as risk in some way.
Yes, sometimes it's actually very difficult to get it on the small children, and it's more meaningful on a older child. I'm talking 4, 5 and above, not in the infants. But even those children, I have a hard time figuring out what to do after I get the report. But I preface if I were to order it, I tell my parents that it is going to be abnormal.
Okay, great.
And I think another thing to also remember is that we know that, as Dr. Konersman said, that the bone density is going to be low when you have a muscle disease. Your muscles aren't pulling on your bones, and so as strongly as they were if you didn't have that muscle problem. And so bone density naturally is going to be a little bit lower. And if somebody's non-ambulatory, they're really not pulling on, they're not putting that natural weight bearing component that can help strengthen the bones. If you're on medications that can decrease bone density, such as the anticonvulsants, or if you're on steroids, then all of those things can contribute to decreasing bone density. And so it's really, again, a multidisciplinary approach to making sure that your child's bones stay as strong and healthy as possible. When they're ambulatory, we want to encourage as much ambulation and this physical activity as reasonably possible. And then if somebody's non-ambulatory, we want to try to encourage time in the stander, or doing anything that we can do to support those bones staying as strong as we can through just natural techniques, and then supplementing early on with vitamin D when necessary, which is usually necessary, and then going towards other medications as needed, particularly in collaboration with an endocrinologist.
Great. Okay. Well, we're at the end of our time. Megan, do you want to give us kind of a wrap-up statement and a forward-looking statement, if we will?
Sure. So the dystroglycanopathies can be really complicated, as you know. There's lots of things that are going on with your child, possibly, but then there's also the other end of the spectrum that have much more mild disease and symptoms. And so capturing all of that is difficult, but extremely important. It's really important to get involved with the registries and to remain hopeful. We know that you have a lot of things on your plate, and it's really hard, and we admire all the families and our patients so very much. And so keep up the great work. You guys are doing a great work. Stay hopeful, because we do expect to get there.
Awesome. Thank you, panel. We appreciate your time today. If we didn't get to a question that you have, please email us at SciFam@curesimd.org, and we'll do our best to get some answers for you. Thanks so much, everybody. Take care.
Thank you.